Good morning, everyone. I'm going to have, if people can, we're going to get started. We want to leave ample time for Gail's presentation. So I'm going to introduce Gail to you. Many of you know Gail Bernstein. She is a long-standing member of our faculty and of this university. She's really helped to shape the Department of Psychiatry over the years. And her career path, which has really been devoted to advancing the care of children and adolescents with challenges, began with her pursuit of a psychology major as an undergraduate back at Tufts University. So Gail has had a long-standing interest in mental health. She's also the child of two psychiatrists, so perhaps she couldn't help that. She graduated medical school from the University of Minnesota and then went and became a badger for a number of years, completing residencies in general psychiatry, pediatrics, and child psychiatry before coming back to Minnesota to do a research fellowship in child psychiatry. And then for the last 30-plus years, Gail has served the department's research, clinical, and teaching missions, excelling in each of those. She's currently an endowed professor, and she's the director of the PANS and PANDAS Research and Clinical Center of Excellence, which she's going to tell us about today. She's also the head of the program in child and adolescent anxiety and mood disorders in the department. But I think one of the most impressive aspects of Gail's career is that in addition to all of her research accomplishments, which we're going to hear about, she's repeatedly been recognized by her peers in psychiatry and psychology and patients as well as someone who provides exemplary clinical service. And her numerous awards, clinical awards, attest to the fact that many others outside of our department recognize Dr. Bernstein for the contributions that she makes and the way that she takes care of her patients. And that's impressive in light of some of the research that she's also been able to accomplish over the years. So some of Dr. Bernstein's earliest research, NIH-supported research, was very innovative work targeting the real-world problems faced by families of children who have school refusal in the context of anxiety disorders. She's conducted a number of NIH industry-sponsored and foundation-sponsored studies over the years into pediatric generalized anxiety disorders, major depressive illnesses, social anxiety, OCD, pediatric autoimmune neuropsychiatric disorder associated with strep, which we're going to hear more about today, and also pediatric acute onset neuropsychiatric syndrome, or PANS. So her work really has spanned behavior and emotion and cognition and brain connectivity and the immune system, all the while maintaining a focus on real-world problems faced by children and adolescents with anxiety. So today she's going to talk to us about her research efforts studying and taking care of patients with PANS and PANDAS. And in keeping with her integrated approach over the last 30-plus years, Gail's research really continues to be driven by what she encounters in the clinic and the lives of real families. So please join me in welcoming our inspiring colleague, Gail Bernstein.
Okay, well, I'm very excited to tell you about PANS and PANDAS, and let's get going here. Okay, so here's disclosure information, just grant support that I've had within the last 3 to 4 years. And we're going to be talking about PANDAS, which is pediatric autoimmune neuropsychiatric disorders associated with strep. The criteria for PANDAS was published in 1998. It was developed by Sue Suedo at NIH, who still remains the primary researcher in this field. The criteria for diagnosing PANDAS would be the presence of obsessive-compulsive disorder and or a tic disorder. And it's a very characteristic subtype of OCD. It has prepubertal sudden onset. And it's very dramatic. Like, families will tell you the exact date that their child started to have PANDAS. They went to bed, they woke up the next day. They were having obsessions about germs and contamination, and they were washing their hands up to 100 times. It is relapsing with a temporal association between a group A strep infection and then remission. So we see relapsing and remission for the pattern. The pandas kids also have associated neurological abnormalities such as choreiform movements or hyperactivity. So Sue Suedo in 2012, so that would be 14 years later, she and a consortium of researchers from around the country came up with a new, broader classification, PANS, and that's Pediatric Acute Onset Neuropsychiatric Syndrome. Again, we have the sudden, dramatic onset of OCD and/or now it's a severely restricted food intake presentation. And this could be due to contamination fears, like you might hear about in OCD, or fears and phobias of choking, vomiting, swallowing, or like you see in eating disorders, fear about weight gain. In addition, they need to have severe acute onset of at least 2 other neuropsychiatric symptoms. And the areas that we probe for include anxiety, like sudden onset of separation anxiety, emotional lability or depression, irritability, aggression, oppositional behavior, behavioral regression with kids that start talking baby talk or start crawling around on the floor, deterioration in school performance or handwriting, sensory or motor changes, somatic symptoms such as sleep disturbance, urinary frequency, and uresis. Now, to give an idea, this newer classification of PANS, it's broader. It encompasses pandas. So pandas would be a subset of PANS kids. PANS can be triggered by infection, such as strep, in the case of pandas, or other infectious agents, such as influenza, mycoplasma, viruses. And it's thought to be also non-infectious triggered in some children by environmental factors or metabolic disorders. The course of the pandas OCD compared to regular pediatric OCD is different. As I mentioned, pandas OCD is explosive. It reaches its peak severity in 24 to 48 hours. It happens overnight. The course is exacerbations and spontaneous remissions. The non-pandas or regular pediatric OCD instead has a slow, gradual symptom onset over months or maybe a year or 2. And it's more of an undulating, waxing, and waning presentation. The age of onset for pandas or PANS is, as reported in this survey of 700 families, typically between age 4 to 9. And this was a study we did here in our clinic at the University of Minnesota, published in 2010, where we compared 21 kids with pandas versus 18 kids that had OCD of the non-pandas variety. And you can see that, oops, no, you can't see. Okay, got to get used to this pointer. Okay, so the pandas kids, their average age of onset was 7.3, whereas pediatric OCD in our sample was 8.7. So even earlier onset than pediatric OCD. This was from our study in 2010, looking at how do kids with pandas present in terms of their associated symptoms. And we came up with some that were highly significant, such as acute separation anxiety, urinary urgency, ADHD-type symptoms, chorea, decline in handwriting, etc. What is the natural course of pandas? A lot of families will ask when they bring a child into the clinic. We know now from infectious disease studies that the OCD symptoms can occur suddenly, even 1 to 3 days before the group A strep infection, and they may present up to 30 days after the infection. These onsets and exacerbations can follow asymptomatic strep throat. So this is why we tell families of pandas kids that if you see an exacerbation of neuropsychiatric symptoms, they should go into the pediatrician and get a strep test. Symptoms we think improve over time, that may be over months or years, and we have noticed now that antibiotics are associated with improvement in neuropsychiatric symptoms. And I would have been a non-believer in that in the past. I mean, I'm the last one who wants to treat a kid with an antibiotic for a psychiatric reason, but it's pretty obvious, and there's certainly clinical consensus now, that treating a flare or the initial onset with antibiotics seems to be associated with reduction in neuropsychiatric symptoms. So it may be that antibiotics actually have an immunomodulatory effect. So let's understand what the pathogenesis is of pandas. You have a group A strep infection and then a susceptible host. So this would be a child that for genetic or developmental or immunological reasons is susceptible to this type of phenomenon. A normal host then will produce antibodies to the strep, but in these particular children, they produce antibodies that are called cross-reactive antibodies. And those antibodies then cross-react with neuronal proteins in the basal ganglia. So in other words, we have antibodies that are now attacking human brain cells, and this leads to central nervous system and clinical manifestations of pandas. The model for this is called molecular, oops, we got an extra Y there, molecular mimicry, and this is the proposed mechanism for pandas and PANS. Think of Sydenham's chorea. It's modeled after the Sydenham chorea pathogenesis, where antigens on the cell wall of the strep are similar to proteins on cells in brain tissue, heart tissue, joints. And the group A strep infects the susceptible host, and it induces an abnormal immune response. And here's another slide going through that again. So through this molecular mimicry, the antibodies against strep then cross-react with neuronal components of basal ganglia cells. This leads to basal ganglia inflammation, and the inflammatory process can cause emotional, cognitive, behavioral, and neurological symptoms. We see spontaneous resolution, but then again, exacerbation when challenged by another infectious or non-specific trigger. And this is supposed to be a depiction of, these are strep bacteria, and then we have, these are antibodies against strep that then can cross-react with neuronal cells. Here's a picture of how it's proposed in acute rheumatic fever. So you have your, plasma cells making antibodies against the strep bacteria. And then in acute rheumatic fever, some of those antibodies are autoantibodies, and they attack heart valve or heart tissue. And that leads to acute rheumatic fever. So this is a case report of a child with pandas, also presented with catatonia, was published in the Orange Journal in 2005. And the patient was treated with lorazepam for catatonia and plasmapheresis for pandas. And a plasmapheresis would be removing the patient's plasma and then replacing it with other clean plasma, or they've modified the plasma and taken out autoantibodies. And what you see in the first slide is before plasmapheresis, inflammation and swelling in the area of the caudate. And then after plasmapheresis, the scan shows a reduction in this area of inflammation. So you're listening to me and very attentive, and I will tell you that there are many people out there that don't believe in pandas. It continues to be controversial. One reason is that there is a debate really as to whether group A strep is coincidental or causal. Kids are getting strep all the time. It's ubiquitous. So non-believers would say, oh yeah, okay, so you have a child who has new psychiatric symptoms and there is an associated documented strep infection. Well, that's just by chance, okay? The other controversy is the autoantibody theory that I've been going through, and it does have support in the literature with some studies that I'll briefly summarize, but not all those studies have been replicated, so we're still trying to gather information to confirm the pathogenesis. There are animal models of pandas that would support this pathogenesis I've talked about, such as, and I'm not an expert in animal studies, but brief summary is that if you immunize a mouse with group A strep, you can induce OCD-type behaviors, repetitive behaviors, and they have found peripheral anti-CNS antibodies and immune deposits in the brain in these mouse models. In terms of immunological support for proposed pathogenesis of pandas, in both pandas and Sydenham chorea patients, Sydenham chorea would be neurological presentation of acute rheumatic fever with chorea movements. They have found elevated serum concentrations of cross-reactive antibodies, and that would be antibodies against dopamine receptors, lysoganglioside, and tubulin, which are components of brain cells. That these levels of cross-reactive antibodies are higher during pandas exacerbations, and they are lower during remission. There is a panel out there now called the Cunningham panel. This is developed by Dr. Cunningham at the University of Oklahoma, where she will analyze the blood of kids with possible immunologically induced neuropsychiatric disorders. And this is just an example of a panel, possible panel on a patient where they have elevation of the dopamine receptor antibody in their serum. So we still consider this type of a panel to be experimental, doesn't really inform necessarily our treatment, but this type of data is being collected on kids with PANS and PANDAS, so we will understand more the meaning of it. Just within the last year, we have started a network of 13 sites to study PANS and PANDAS. And this is the list of the sites, including University of Minnesota. The PI for this project is Sue Suedo at the NIH. She is the Chief of Pediatrics and Developmental Neuroscience. And the goal of the centers are to provide excellent evaluation and care of kids with PANDAS. We just opened our clinic in November, so we're seeing new kids on Monday mornings. We plan to characterize these patients, identify biomarkers and disease mechanism, study immunomodulatory interventions, which could include nonsteroidal anti-inflammatory drugs, prednisone, and intravenous immunoglobulin, and follow kids longitudinally. In order to be part of the PANDAS consortium and the PANDAS Center of Excellence, these are some of the types of data that we plan to collect from kids coming in. Certainly, we'll be doing psychiatric assessment, developmental and medical history, the family history of autoimmune diseases, which are much more common in first-degree relatives of kids with PANS, testing, physical and neurological exam, collecting blood and biological samples, and offering additional consultations and testing as needed. Each center has to have a child psychiatrist or behavioral pediatrician to be directing the activities in the clinic, and hopefully consultants in infectious disease immunology, rheumatology, neurology. We need screeners to identify and schedule patients, and that's where our intake team comes in, and they're all here, and they've been helping me a lot with finding the right cases for clinics. And then nurse, psychologists for testing, social worker, research assistant, therapists, and fellows to treat the patients, and access to inpatient child psychiatry as needed. This is the PANS rating scale. This was developed by Tanya Murphy at the University of South Florida and myself, and it's what we're going to be using as a scale to follow these kids over time, to find out, quantify their obsessions and compulsions in terms of frequency and severity, and look at associated symptoms to identify which ones we're seeing in our patients. And there's some unusual ones in here that some of the researchers at other sites have seen in their PANS, kids with exacerbations such as hallucinations, that one I haven't seen yet, suicidal ideation and behavior. So we're piloting already using this instrument in the clinic. And our data and rating scales will be going to a centralized clinical trials database at NIMH, and biological samples will be sent to an NIMH repository. So now just a little bit about how we're looking at treatment in our clinic right now. In terms of the infectious disease workup, it would be informed by the history of the given child and physical exam. But commonly we are getting rapid strep and 24-hour culture to look for strep as the etiology of the sudden onset of neuropsychiatric symptoms. We look for other areas of the body that we might want to culture for strep, and so we recently had a kid that looked like she had impetigo on her face, and we did culture that to look for strep. Younger kids may have strep in the rectal area. We are commonly getting the ASO and the anti-DNA speed titers, which are anti-strep antibodies that we can assay for. One set of titers is not helpful, but if you get a series and you see an increase in titers or a decrease, that can help you. And then there are other possible infectious disease etiologies that we can look for, like swabbing for influenza, if there's a history of cough and pneumonia-type symptoms, mycoplasma, viral titers. The treatment of the infectious disease part of PANDAS or PANS is something that we are recommending and doing in our clinic. First off, we tell families that they need to get the throat culture if there's a direct exposure to strep, like a sibling or it's rampant in the classroom. Of course, if they have symptoms of strep, such as fever, stomach ache, sore throat, lymphadenopathy, get a strep culture. And we also recommend that they go and get the culture if there's an exacerbation of neuropsychiatric symptoms. It's now recommended, and this is, there are 3 papers that are in press right now from the PANDAS researchers, one about assessment, one about infectious disease assessment, and one about immunomodulatory treatments. So in this one, which is Dr. Cooper Stock at the, he's the head of ID Pediatrics at University of Ohio, I believe. And in his paper, we are recommending that even for PANS, as opposed to PANDAS, where we don't have a strep etiology, that if they come in with exacerbation of neuropsychiatric symptoms, we will recommend initial course of antibiotics, even if the tests are negative. And there's then a decision to be made about choice of antibiotics and duration of treatment. So in the paper, he recommends the usual 7 to 10 days, but I would say many of the PANDAS and PANS researchers are treating for, I would say, 2 to 3 weeks of antibiotics. And the paper states, aggressive treatment of group A strep seems prudent as a means of mitigating the risk for neuronal injury. And you have to meet some of these parents. I mean, like, they want it. They want antibiotics. Yeah. Okay, so then there's also the question of prevention antibiotics. There have been, these would be kids, well, this would be daily antibiotics to prevent new strep infections. There have been 2 studies looking at prophylaxis. They had contrasting results. One of them showed that it didn't help prevent strep infections. The other showed that it did. But in our clinic now, for a child who's had multiple severe exacerbations associated with strep, I mean, this is a kid who is severely ill psychiatrically, can't go to school, is regressed, peeing in their pants, having OCD obsessions. If we have that history that it's happened several times and it was associated with strep, we may consider prevention antibiotics because they may prolong remissions and decrease exacerbations, and they may prevent neural injury. And we follow the American Heart Association guidelines for treatment of prevention of acute rheumatic fever. So that would be, in most kids, Pen VK 250 milligrams twice a day. Now, I want to tell you about the immunomodulatory treatments that are being looked at. Again, there's a new paper in press that discusses this in depth. Considerations are nonsteroidal anti-inflammatory drugs. That would be like ibuprofen or naproxen, corticosteroids, oral or IV, intravenous immunoglobulin, plasmapheresis, and then at Stanford they're using rituximab, which is a monoclonal antibody that targets the CD20 receptor on the surface of B cells, and then it destroys autoantibodies. It would be, I think, like a chemotherapy. So the paper on immunomodulatory treatment states, Immunomodulatory treatment for PANS and PANDAS requires an individually tailored approach with the intensity of the therapeutic intervention matched to the severity of the child's symptoms and disease trajectory. So in the paper, they talk about mild, moderate, and severe PANS, and what immunomodulatory treatments you might consider for mild, which might be like a nonsteroidal anti-inflammatory drug. Moderate, you might consider prednisone burst orally, or severe, you might consider IVIG. The hypothesis on IVIG, which I'm going to be talking about now, is that treatments that remove or inactivate autoantibodies and replace them with normal antibodies will be of benefit to use with PANDAS. And this would be similar to the IVIG, and that stands for intravenous immunoglobulin. It's giving someone IgG antibodies pooled from hundreds of donors. It's indicated for Sydenham chorea, Guillain-Barré, and other antibody-mediated autoimmune encephalitis presentations, such as this anti-NMDA receptor encephalopathy. So now I would like to go over the research of what we know about the benefits of IVIG. This study was done in 1999, so right after PANDAS was described and reported. It was done by researchers at the NIMH. Small study. They took moderate to severe kids with PANDAS. They gave 9 kids got IVIG, 10 got intravenous placebo, sham IVIG, and then 10 of them had plasmapheresis. So that's where they take out your plasma and give you new plasma. IVIG is just infusing antibodies. And they found dramatic benefit in that study. So they were using the Children's Yale-Brown OCD scale as an outcome measure. They found with the IVIG treatment 45% reduction in severity of OCD with the CY box. With the sham IVIG, they had no benefit, no reduction. And with plasmapheresis, they had 58% reduction of severity. And they found that the gains were maintained at 1 year. Then there are 2 papers with just, it's more like case series, like 5 kids in each paper, where they gave the plasmapheresis or the IVIG to patients who had OCD or tic disorders, but they didn't have the PANDAS presentation. And they showed that it did nothing. So, like, don't try doing these treatments for kids who just have OCD. It's not going to work. Now, just this year in the Orange Journal, they finally published the recent IVIG study that was done at the National Institute of Mental Health with researchers from Yale University. This was 35 kids with PANDAS, and they screened over 1,000 kids to enroll 35. So they were being like really meticulous about who they took. And interestingly, 2 of my patients were screened over phone and went to NIH for the study. And one of them was enrolled. The other one was assessed but was not treated because she wasn't severe enough. But I thought that was kind of cool that a couple of my patients were in the study. So they had this double-blind placebo-controlled phase of the study where they were randomized to get either IVIG or a placebo infusion. They give 2 infusions, day 1 and day 2, pretty high dose. And then they go home, and then they come back 6 weeks later, and they're reassessed. And then if they are not improved or continue to have significant symptoms, they then get open label IVIG for if they're a non-responder. And then, so that's the second visit to NIH, and then they do 2 more visits at 12 and 24 weeks for follow-up. So the study, unfortunately, I guess, was not definitive. The double-blind placebo-controlled phase really showed no significant difference between the 2 groups in reducing severity of OCD. The IVIG group had a 24% reduction in OCD symptoms, and the placebo group, they were expecting probably no improvement based on the first study, but there was 12% reduction, and it was not significantly different. And responder status also was not significantly different between the 2 groups. 24 of the kids were non-responders, so they got the open label IVIG. So there will be some kids that got placebo and then IVIG treatment 6 weeks apart, some who got IVIG and then 6 weeks later got IVIG again. Then they looked at those kids, anyone who got at least 1 IVIG treatment, and they found benefits from the infusions at longitudinal follow-up. So that's kind of interesting, a little bit confusing. So this paper has been controversial. There was an editorial about it in the Orange Journal saying, okay, now we know IVIG doesn't work. But there were methodological problems with the study. And I just wanted to highlight those. One, of course, was sample size. It was a pretty small sample. And improvement from the IVIG during the double-blind phase was small, smaller than in the 1999 study where you had about 50% improvement. And the placebo response rate was higher than they expected. It wasn't 0. So they really had a smaller effect size and inadequate power. Now, there were a couple other problems with the study. One was that everyone was given antibiotics throughout the study because they wanted to prevent new infections. But now that we're learning that antibiotics tend to reduce the neuropsychiatric symptom severity, this probably confused the role of the efficacy of IVIG versus placebo. And the other thing that happened during this study is that parents apparently were on the internet talking to each other, and they figured out that if they definitely wanted this IVIG, because it's really expensive and it's not covered by insurance, and it's like the hope for these families that it might cure their kids. So they came back to the NIH after 6 weeks, and they were saying, my kid didn't get better with the first infusion, as a means, they believe, to get the second infusion. So that could have led to some of the lack of benefit determined after 6 weeks. And there were, I think, 5 kids in the study that developed new infections during the study, even though they were on prevention antibiotics. So I'm going to end with, so now there is a proposal to do another IVIG study that would be larger sample size and fix some of the methodological flaws. So it's proposed to be done at 5 sites, including the University of Minnesota, hopefully will be included. And it will evaluate whether a single blinded dose of IVIG is superior to placebo. in reducing PANS symptoms, and they want to enroll enough kids to have 96 that actually complete the study. And it will also assess utility of biomarkers in predicting treatment response, such as, serum levels of autoantibodies, et cetera. And the hypothesis is that one single dose of IVIG, this is 1 gram per kilogram per day for 2 days, would be superior to placebo in improving OCD symptoms, and it's going to be for PANS kids, so kids that have the sudden onset of the neuropsychiatric symptoms that we talked about, not necessarily triggered by strep. So double-blind control. They are going to do 3 weeks of antibiotics before the infusions. So that way we'll get out responders to antibiotics, and then they'll go right into the IVIG or placebo for 2 days. 1 month later, non-responders will get the other infusion. So it'll be like a crossover design. And they'll be followed for hopefully two years. So that's the latest on PANS and PANDAS. And I'm open for questions. George.
Yes, thank you, Gail. Very nice presentation. There's a lot of work that you have put into this over many years. Use the mic? Okay, I'm using the mic. So thank you for that. When I was growing up, polio was an endemic disorder. And children got polio, they played together, and they gave it to each other. But it wasn't just children. Roosevelt got polio when he was in his 30s or 40s. So I'm wondering if you have some ideas about the developmental issues of this process. You said between 7 and 8 years of age, you see OCD and you see PANDAS or you see PANS as possible peak incident periods. Does that mean there's something immature about the immunological system at that age? Is there something immature about the CNS at that age? Is there something about how 7-year-olds don't wash their hands enough at that age? What is this a disease only of children? And perhaps we need to think about OCD that develops later in life as requiring a workup for these processes.
Okay, yeah, thanks, George. So, good question. I think that it's certainly the children as opposed to the adults who are exposed and susceptible to getting strep infections. As we get older, there's less likelihood of that. So that's one thing. And I'm sure that there are developmental factors in terms of the brain and the immune system. And I would say that some of the researchers do entertain the possibility of onset of PANS and PANDAS in like adolescents and adults. It's just that it's going to be much more likely that it would present in a child. So, yeah, the waters are muddy. I mean, we've had people calling in. I think, didn't we have like a 23-year-old who called in and wanted to be seen in the PANDAS clinic? I don't have additional thoughts on that.
I have a question about the PANS syndrome. Is that is OCD or restrictive eating exclusively?
Yes, you have to have one or the other, and then you have to have associated neuropsychiatric symptoms, and I think 2 categories. So the tics are not part of the required neuropsychiatric symptoms. It's just OCD or the restrictive eating.
And are tics required for pandas?
No, because it's OCD and or tic disorder. So you could have OCD without a tic disorder and still be diagnosed with pandas.
Okay. The problem I have with the PANS concept is there an operational definition of sudden and dramatic? That seems.
Well,
does that
there
mean
is
that the symptoms are absolutely not present prior, or they could be present but they get a lot worse? And how sudden is sudden? All of those things.
Well, sudden is like a key part of the criteria. It's not like operationally defined as 24 to 48 hours, but it's not going to fly if the kid comes into clinic and they've been having months of OCD subthreshold symptoms. Okay, we see this classically, that the kids are fine and then they're not fine. It's a sudden change.
And they were not OCD before at all?
No.
So this.
I guess it's possible that you could have OCD and then get pandas, but that's not what we're talking about. We're talking about someone whose pre-morbid psychiatric presentation was they didn't have OCD, and now they do.
So it would not include other disorders that may come on suddenly, but don't include OCD symptoms. Like
no, but
mania or
there's a lot of associated, like separation anxiety. They have OCD, and they also overnight are now refusing to go to school, clinging to the parents. And the symptoms are supposed to be related to the etiology, the area of the brain that's being affected with the immune changes.
Where does this restrictive eating disorder?
Why did they add that?
Yeah, where does that come from? That doesn't sound like that's a basal ganglia Sydenham chorea variant.
Yeah, I thought it was a little unusual when they came up with that, but apparently this was before I became part of the Pandas and PANS consortium, that there were researchers and clinicians that were seeing that presentation enough that they put it into the definition. And one reason that I think tics might have been taken out of the definition as in pandas is that tics they pretty much always have a sudden onset. You either have tics or you don't. And so that became a little confusing because kids' tics will start when they're like 5 or 6 or 7. So that one was a goner. But then they put in this risk, and these are kids that are really ill. I mean, they stop eating. They won't eat. They're losing weight. They're cachectic. We've had referrals of kids from like Julie Lesser at the children's program, where they're put in for an eating disorder, and then you peruse the history more carefully, and it's sounds more like PANS. So yeah, I think that's a really excellent question. What led to putting that in there? But it's definitely not as common as the OCD.
Are there any studies of eating disorder patients, adolescent eating disorder patients, as a whole, or for antibodies or adult anorexic patients to try to establish a relationship?
Well, there's some case Oh.
Yeah, I think I got the answer for that.
Okay.
I have a 17-year-old in my hospital now. He's diagnosed at Accenture for psychosis.
He has OCD. So he got himself on 150 milligrams of haldol-decanoate at 17 years of age. He won't eat. Why won't he eat? Because if he doesn't eat, he won't poop. If he doesn't poop, he won't have to touch himself. If he doesn't have to touch himself, he won't be contaminated. And the whole thing starts from an OCD perspective that leads to, I'm not going to eat so I don't have to poop.
Okay, we have a question from Dr. Klein.
Thank you, Dr. Bernstein, for an excellent presentation. But I want to get your comments on the embarrassing problem of the placebo response. I noticed that a couple of the studies you showed us had no response whatsoever, which is, of course, the desired wish, where the treating group had a clear response. One study you did say had a 12% placebo response, which is kind of what we're used to. What about that? How was it that you didn't have anything, any placebo response to those a couple of those studies?
Yeah, the 1999 study.
Yeah.
That's a good question. I mean, you would think that the 12% placebo response rate is very understandable. I mean, you're getting an infusion of something, and there's a 50% chance that it's IVIG. So your expectancy, we think, would be to respond to placebo. Although, as I was mentioning in the more recent study, the families were probably underreporting response, so they could get another try at IVIG. But yeah, that 0%, that's not the usual, but I think in OCD drug studies, placebo response rates are lower than they are in, say, with depression or other anxiety disorders. That OCD is, pretty more refractory to placebo treatments than other child psychiatric conditions. Mm-hmm.
I have a quick question, Gail. In the NIH study, you mentioned that they screened 1,000 participants or potential participants, and they enrolled 35. What was the reasoning for being so highly restrictive, and do you think that had an effect on the results of the study?
Yeah, isn't that a huge number? They were wanting to, I think, be sure that there was an association with strep and the right timing, and I was just like reading that study, and it had to be there. But yeah, anytime that you don't get more of a garden variety sample of kids, more like what's out in the community, you're not going to be able to generalize your data, and you're not going to be able to get a big enough sample size. I mean, it's sad how small that sample size was. And I mean, that study took years to do. So yeah, I think probably they were maybe too rigid on who went into the study, and then we have a problem of can't interpret the data because there are not enough subjects. I don't know if that answered your question.
Yeah, thank you. One other question?
Thank you for the presentation. I guess I was curious, one of the earlier studies, I think it was the 1999 one, it noted that the plasmapheresis group did pretty well, I think. And if I remember correctly, they did better than the IVIG.
So, yeah, slightly better. Right? I don't think it would be statistically significantly different, but wasn't it like 58% versus 45 or something?
Sure. So I guess I'm curious, why are they further studying IVIG and not the plasmapheresis option?
Well, just FYI, there was no control group for the plasmapheresis, and it wasn't really blinded. I think you would know if you're getting plasmapheresis. I mean, it's more risky. I think you have to do like 5 different times. You have to like take out the plasma and replace it with blood products with new antibodies. So it's just it's more side effects, more risk, didn't have a placebo control to it. It is, though, in the immunological paper coming out, it is the recommendation for if you have a patient that has like that NMDA receptor encephalopathy and they're like psychotic and really ill, some groups might go straight to plasmapheresis, but it's not very practical for a treatment. I mean, it's kind of scary, you know,
Sure.
to put a kid through that. But if it's life or death, or you might consider it.
Okay. Thank you.
Okay, we are at noon, so let's thank Dr. Bernstein one more time.
You have been